I don't have so much time. This time I can show my nice T-Rex slide. I forgot to show this yesterday. So, based on my understanding of immunoregulation, what we ideally want to do is, and there's lots of evidence that at least this is true, you have an inflammation in the pancreas that involves different antigens and different T cell populations. You're going to have effector cells that destroy beta cells, but you're also going to have regulatory cells that prevent destruction of beta cells, and these can see islet antigens. So the hypothesis is really, if you can augment this part of your autoreactive repertoire, these are autoreactive Tregs, okay, then you would be much better off because this balance is going to shift. You can also look at this in terms of balance shift, like we discussed this morning. Let's say you have more cells making IL-10 than gamma interferon. If you can skew this balance, you would be better off preventing the disease. So that's really what we're trying to do. Why are Tregs therapeutically important? Because of two things. One is they can bystander suppress. Two is they can induce infectious tolerance. Bystander suppression expression created by Howard Weiner. Infectious tolerance comes from Hermann Waldman. They're both effects that could be very beneficial. So let's assume you immunize with something that induces Tregs, oral insulin, a DNA vaccine that makes a Treg to an islet antigen. This cell will circulate through the body. In ideal cases, it will make cytokines that protect from type 1 diabetes. When it arrives in the pancreatic lymph node or the islets, it will suppress their antigen-presenting cells. There's good evidence for that. And these antigen-presenting cells will then become less able to push your effector response. It's with that that you have a site-specific, generalized immunosuppression. The good news is it's site-specific for the pancreatic node. The other good news is it can suppress all kinds of other specificities, which is what Howard Weiner means with bystander suppression. At the end of the day, it could also induce infectious tolerance if you induce more of the like kind regulatory cells locally in the area. Histologically, it looks good. If you give oral insulin, for example, you go from this insulitis to this type of very low degree insulitis in the mouse models. Mechanistically, what's the evidence for that? There's now two papers, I think, that have provided the best proof. One was one from us in 1999, and one is one from Bluestone, I think, in 2005, by Bluestone and Kizzy Tan. So what you do here, you take a donor mouse, you give it oral insulin, you take Tregs out and you transfer it into an otherwise naive mouse. These are the virus-induced mice that destroy the beta cells with a CD8 response. So what you can see is two things. One is the insulin-induced Tregs that you transfer only proliferate in the pancreatic node, but not in the spleen and mesenteric node. The other thing is that they only suppress in the pancreatic node, not systemically, the CD8 T cells that destroy the islets. It's a similar thing that Jeff Bluestone has found with BDC 2.5 Tregs in the NOD model. So the concept that you can make an antigen-specific Treg that can only become activated and act in the pancreatic node, that then suppresses there the reactivation of a variety of autoreactive specificities, I think is therapeutically very, very good concept, and that's why we should pursue antigen-specific vaccines in type 1 diabetes. The way we have done this, and I'm going to close on that and with some discussion on what reagents could be given, we have done this by combining anti-CD3 and nasal insulin or oral insulin or DNA vaccines with insulin or GARD, and shown that they have synergistic effects, okay? So you give a suboptimal dose of anti-CD3 in recent onset diabetes in the mouse. Then you give at the same time oral or nasal insulin, and you can double the degree of protection from what you would see with anti-CD3 alone. And that's really something you would ultimately want to achieve in the human situation. You want to give an anti-CD3, and ideally an antibody that favors induction of Treg, as we've discussed before, and then combine this with an oral or nasal insulin, maybe a DNA vaccine, or maybe the GARD from Diamyd, and so forth. So let's close on this. I'm going to skip these slides as to not go any further, and discuss what type of immunomodulators might be promising right now in type 1 diabetes. So anti-CD3, we talked about, and there were two trials where anti-CD3 delayed the decline of C-peptide in humans in recent onset diabetes. It's a promising drug because it can also favor induction of regulatory cells. There was one trial now with rituxan that gave promise in preserving C-peptide also in recent onset diabetes. And there are pending trials with CTLA-4 Ig and ATG where we do not know the outcome. Similarly, we do not know the outcome of anti-inflammatories in recent onset diabetes. There were two promising trials, one with GAD alum and one with insulin as a DNA vaccine from Bayhill, that have shown similarly preservation of C-peptide. So you could envision some combination of a type of insulin or GAD alum with one of these drugs, anti-CD3, maybe rituxan, that have been shown to not have profound side effects. Let me skip this, because we discussed this yesterday. So I wanted to thank the people that did the work. Damien Bresson with the combination therapy. Chris Filippi has done most of the viral work together initially with Horst Christman. Dirk Hohmann worked on the regulatory cells initially. And Ken Kopiters has done a lot of work on the pancreatic histology I showed you in the beginning. Thanks very much.